Well, good morning, everybody. My name's Carrie Comer, and I work with the Health Systems Transformation and Innovation team here at the Department of Health in the Secretary's Office. You're joining us today for the second in a 7-webinar series related to Health Systems Transformation and Innovation. This session is focused on delivery system reform. So we're going to just start off by kind of describing the setting we're in here. We're calling this open spaces, and this is an opportunity for public health staff and stakeholders to learn more about health system transformation activities going on around the state. This is also a safe place to ask questions, so if you have questions, we'll be taking those at the end. This session is being recorded, so those of you on the call, now that you can hear us, please either type your questions in the question box on the go-to menu bar or raise your hand and we can try to unmute you at the end of the call. So we really started these open spaces to focus on the Healthier Washington initiative, and we really wanted to get everybody up to speed before it really kicked off, which will be happening this Friday, that official kickoff. For those of you that haven't been as involved in this work, we received a $64.9 million grant from the Centers of Medicare and Medicaid Innovation in December. And the plan for this is really, you can tell this in the model from the strategies on the right, really healthier communities, integrated care and social supports, and paying for value, and that as a state is a first mover. The activities are kind of buckets of work are in the middle to achieve the goals on the right. And so our goals are to improve population health, transform the delivery system, and then reduce cost, our spending in some areas. So we put this series of webinars together to look beyond SIM. And again, SIM is another word for the Healthier Washington initiative. A couple weeks ago, many of you joined us for the insurance and coverage reform webinar. And today we'll be focusing on delivery reform, and so we really identified these kind of buckets or areas that really helped shape where transformation is occurring across the system, not just in one initiative like the Healthier Washington initiative. And really this work is really based on the triple aim. Many of you have heard of this. You've seen a lot of different versions of this image. And the triple aim is the focus and the framework of the ACA and the National Prevention Strategy. And so we'll be using this model to drive this work across the system and across our state moving forward. And just a quick reminder about the triple aim. So our focus, it's the better health, better care, and lower cost. So for better health, we're looking at really improving the health of whole communities or populations through health promotion, education, and collective impact efforts. We're also using this to focus on upstream causes of health issues to really benefit larger communities. For better care, we're improving the quality and experience of care. And for lower cost, we really think if we improve the health of the population overall on the care they receive to decrease redundant and unnecessary services, and on transforming the way we pay providers for services, that we'll have a health system that's more effective and less expensive, and which will make it more sustainable. So now I'm going to pass things over to Caitlin Safford. She's the Policy and Communications Lead for Health Systems Transformation and Innovation, and she's going to really provide an overview and dive in a little deeper into this element of delivery system reform.
Thanks, Carrie. So I just want to let everyone know that we're keeping all of these pretty high level, and we're not going to get into too many details because they're extremely complex subjects, and we wanted to sort of just tease you all with some information, hopefully coax out some questions, then we can dive into details there. There are a lot of people in this room that are probably bigger experts around this topic than just me, so please, during the question and answer period, if you could share your experiences or your knowledge about this topic, that would be great. I think that would really enrich everything. We're going to be covering a couple of high-level concepts related to delivery system reform, but I'm going to start with an overview of what delivery system reform is. So many of you probably have heard about the 2001 IOM Crossing the Chasm report that was released and kind of outlined a lot of the basis of what reform looks like now in the modern age over the last 15 years. And they had some elements of delivery system reform listed in that report. including figuring out how to redesign these care processes to incorporate more evidence-based practices when we're delivering care to patients. Effective use of information technologies, really trying to bolster our information systems to actually help providers and patients connect better around their care. Workforce development is a big piece of it, and making sure that the current workforce and any future workforce related to clinical care is ready to take on the new ways we're going to be delivering care across our system. We also are focusing a little bit more on team-based care and what it looks like to care for a patient in a team environment, and what that means essentially for responsibility of a clinic to care for a person in that way. Care coordination is probably one of the keystones of delivery system reform, and our hope for that is that if we can coordinate all of this care that many people have across different specialists, across their behavioral health care and their physical health care, that we might reduce some of the redundancy that occurs already in our system and make care a lot more about quality rather than the quantity of services you receive. Additionally, we also want to make sure that what we're providing to patients is actually helping them, that their health outcomes are actually getting better and the performance of the providers is improving. And so there's a lot of quality measures and quality improvement work that goes into delivery system reform, and a lot of ways at looking at accountability and holding providers accountable for the health outcomes of their patients. There's a focus on these two following areas and wanting to really shift the delivery system from a fragmented system that we have now that really works in silos. You have different clinics that kind of work on their own focuses. You have specialists, a variety of specialists that work on several different pieces of care. You have mental health care that's in a separate location. You have hospitals that do a variety of things that may or may not have clinics connected to them. And so what we're really trying to aim for is a more integrated delivery care system where information is being shared across all of those providers to better serve the patient and make sure the patient is at the center of the care, not the provider. This also has a lot of ramifications for how we pay for care and what that looks like in payment. A lot of the way we deliver care is actually driven by our fee-for-service system and getting money per service you give rather than giving money for the value you provide in the care you give to a patient. And so we're going to be jumping into payment reform, which is extremely complex, in a couple of webinars, not our next one, but our first one in March, on March 10th. And all of these elements are intended to be sort of integrated together. That's why they were a series, because one really can't be successful without the other ones also being successful, all of these elements. So when they work together, then that's what really is going to transform our system as a whole. So we'll get more into that in March. So our first delivery system reform concept we want to go over is the patient-centered medical home. And the reason why I've chosen these concepts is because they were the ones that had the most incentives actually outlined in the Affordable Care Act. So the patient-centered medical home, there are several bodies that actually certify patient-centered medical homes right now. And these are the 5 high-level sort of elements of a patient-centered medical home. That the care is comprehensive, that you have a team of providers dedicated to a patient to actually deliver evidence-based care that could be very well-rounded, including preventive services, potentially behavioral health care, and even having chronic disease care all located in one area or at least connected to one primary provider. And then we want that care to be very patient-centered and focused on what the patient needs and not necessarily creating unnecessary services for them just to get more money delivered into the system. We also want to, like I said, coordinate care better across all these different providers and serve as sort of a nexus for that provider for all of their information to get back to them. Patient-centered medical homes really strive to make services actually accessible. Sometimes they offer late evening appointments or weekend appointments so that more people can get access to them and they don't have the traditional business hours that many people can't take time off work to actually get to the doctor for. And lastly, there's a big focus on improving quality and safety for patients. We want to make sure the care they're receiving is actually quality care and that it's safe care, again, based on evidence so that they can actually be effective in improving the health of the patient. One of the tools related to patient-centered medical homes is this shared decision-making concept. And I'm just going to read the actual definition so everybody is clear on what this entails. It's a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account taking into account the best scientific evidence available, as well as the patient's values and preferences. And so sometimes these can actually be in the form of informational tools that the patient can see in front of them, and that the patient and provider can work through a worksheet together to figure out the best treatment options for whatever condition they're discussing. So we wanted to use this example of one of the tools that Carrie actually was able to find was a bariatric surgery tool, and deciding if it's appropriate to have surgery, what kind of surgery you want, what are the risks involved with that surgery, making sure you understand all of the risks involved with the surgeries, any type of surgery, so you can really decide what you think is the best one for you. And it's not necessarily the provider just making a decision for you and you not having any say. That way, the provider knows that you will be more dedicated to actually improving your health as well, because you're invested in the decision you've made. The shared decision-making tools are actually a piece of the SIM Healthier Washington initiative. There is some money allocated to work on some decision-making tools for the system, and as a state that we can use to drive forward some certain quality improvement metrics in certain services. I think one of the focuses they're going to do first is pregnancy, and really getting people to be able to carry their baby to term to 40 weeks, 39 or 40 weeks. So it'll be pretty interesting to see what they come up with, and the medical director at the Healthcare Authority, Dan Lessler, is in charge of that particular portion of the project. There were some ACA incentives around patient-centered medical homes. In general, this was just called out in the law several times as a method that people should look into in terms of delivering care. But the Center for Medicare and Medicaid Innovation actually did have some money set aside for primary care demonstrations, particularly in the federally qualified health centers. And it's all still, most of this in general, is all still based on either seeing Medicare or Medicaid patients. So the SIM Healthier Washington initiative has a basis of Medicaid in our public employees. And we're hoping that because we're changing the way we do things there, that it'll then spread to the private side as well. Well, in the same way, they're also doing a lot of that with Medicare Transformation, and using Medicare as a first mover to really transform how we do care in the private side. This is one of those examples. And so in order to be able to be a part of this project, you have to see a certain number of Medicare patients in your FQHC. I think the level is 200. And they have to be on the strict Medicare Part A and Part B coverage, not Medicare Advantage, just for any specifics that you needed. And the hope is that all of these FQHCs participating will achieve level 3 of NCQA certification. The National Committee for Quality Assurance, I am hoping that's the correct way to spell out the acronym. They actually provide a certification for people going through patient-centered medical homes. It's the most common certification that there is right now. And they've actually already had some results from these projects. And there was a 2012 study around implementing primary care patient-centered medical homes. And they found that they did reduce inpatient visits to hospitals and ED, emergency department or emergency room visits, which is a good sign. That's kind of the goal of a lot of this stuff, is to reduce ED visits and reduce hospital readmissions after some sort of surgery or procedure that you had done and you were discharged from the hospital. You can then just do your follow-up care with your primary care provider and have that connection between your hospital or specialist and the primary care provider. And then our next delivery system reform concept are accountable care organizations. There has been a lot of chatter about this lately. This isn't something that's been happening on the East Coast for a while, but it's now come full force to our state, and so now it's affecting the way that we're looking at some things. So accountable care organizations in general are groups of doctors, hospitals, and healthcare providers, possibly clinics, who come together voluntarily and form an organization that is, the goal is to deliver high quality care to their patients, that is coordinated and that is based on paying for value and not encounters. Just as we've been talking, a lot of this, again, like I said, is based around how we transform payment. The ACO is pretty much inextricably linked with payment. It's hard to talk about it as a delivery system reform concept without also talking about it as a payment reform concept. So I'm going to try to stick to the delivery system reform and go in a little bit to the payment, but mostly it's going to be about delivery system. So the goal in terms of if they're able to work together enough to coordinate the care of their patients and really achieve high-level patient outcomes, then the savings that will occur because they've tried to work together and coordinate that care, and the duplication of services has been reduced, ER visits have been reduced, readmissions have been reduced, then all of the entities participating in that particular organization could potentially share in the savings that you've achieved by delivering this higher quality of care. That's the goal of an ACO. And the way that they may be able to deliver some of their savings is through actually taking on the risk of paying for the patients if they're not successful. So if they don't actually improve health outcomes and they're actually going to be paying, they'll be in the red and will have to pay out what other additional costs they've incurred trying to help these patients because they didn't coordinate care well enough, or there were too many readmissions to the hospital, too many ED visits because they didn't have a centralized place for people to go to get primary care. And so, like I said, and when we go back to payment, that's what a lot of these ACA, Affordable Care Act incentives are actually geared around, is trying to transform the way we pay for Medicare. And so these three programs listed on this slide are all related to Medicare specifically, mainly because they're really hospital or insurance plan driven, and a lot of hospitals, the basis for them is to serve Medicare patients. So first you have the Medicare Shared Savings Program. This is the most common program. It's actually the only main program that's open for application anymore. And we have a couple in our state, which I'll go into when we get to our implementation in Washington section. And the goals of this program are to promote accountability for care of the Medicare fee-for-service beneficiaries. It requires coordinated care for all services provided under Medicare fee-for-service, and it encourages investment in infrastructure and redesigned care processes. And so for those shared savings programs that are able to show enough, gumption and that they're actually doing a good job, they could additionally apply for the advanced ACO payment model, where it's at a supplementary incentive program that will test whether an advance in payment will actually increase the participating in the shared savings program, and then whether advance payments will allow ACOs to improve care for beneficiaries and generate Medicare savings more quickly and increase the amount of Medicare savings. So actually paying in advance for them to transform these delivery systems. The first one of these models that we saw was the Pioneer ACO model, and it came out very shortly after the ACA was passed. I think it was like in 2011 that the first applications were released. There aren't very many of these across the country. There's just a few, and we are just now getting some data about how successful they were, which is mixed. I don't think there were only a couple that really lost money entirely, so I don't think anyone lost money, but not a lot of people also gained the shared savings they were hoping. Not a lot of organizations gained the shared savings. So it was a lot of investment for not necessarily a lot of benefit yet, but they're still testing it and still carrying out the model. So the Pioneer ACO model was designed specifically for those who were already and able to coordinate care and integrate care better in their community. Maybe they had been doing it for a long time before, and this just gave them an impetus to actually try to transform the way they do payment. And then the last thing I want to talk about in terms of a concept is this just general underlying idea around information technology and information systems, and how crucial they are to making sure all of this care coordination actually can occur, to making sure that we can report on the quality of care and understand, and different providers can track how well that patient is doing in achieving their health outcomes, which then leads to holding providers accountable for the health outcomes of their patients. And so the next webinar that we have in 2 weeks, I'm not sure exactly the date, I can't remember right now off the top of my head, but that one will be focused on data and technology reform, because this was another cornerstone of the ACA, and there was actually another piece of legislation that came about to actually bolster the infrastructure for information technology. Okay, we want to make sure that everybody can try to get a sense of what it's actually like for a patient to go through a patient-centered medical home. And when we're going through this character study, as we are calling it, we want to make sure you think that this is in the future, like way in the future. We've solved a lot of our problems. We've gotten our infrastructure for IT working, and so that's there for people to rely on. We have a lot of information and data about how well patient-centered medical homes work, and so this is the traditional model of care in the future. So just keep that in mind, because we know that people aren't quite here yet, but this is how we're envisioning the future system. So I want to introduce you to Rosa. She is a 37-year-old mother of 3 who just moved to Simpletown, Washington a few months ago, and she has a chronic condition. She has asthma and has had it for most of her whole life. And just as a side note to tie in our first webinar, she purchased a silver plan on Washington Health Plan Finder, and actually did so because she has a chronic condition and wanted to make sure she had enough coverage to be able to manage that chronic condition effectively. So Rosa needs a physical, and she just moved to a new town. She doesn't have a provider nearby, and she's not anywhere near her old town, so it's not like she can easily travel to her old provider. She hasn't had a physical in 3 years since her last child was born. And so what she does is she goes online and checks her network for her plan to see who's nearby. And then she takes the small pool of clinics that she received from her network and compares it to the all-payer claims database so she can see which clinic gets the best quality outcomes for her area. And she finds Clearwater Family Practice, because that one, at least the payment for the services was lower, but they also had really great quality outcomes. So that was a good middle-of-the-road one for her. So she calls Clearwater Family Practice, and what her concern is that she can only get an appointment for either the evening times or on the weekends, because her partner needs to be able to watch the kids, and he won't get home from work until the evening time. So that's really the only time she's available for an appointment. So she calls Clearwater Family Practice, and they actually offered her a same-day appointment, which was a surprise to her, but she wasn't able to take it because she didn't have any babysitting responsibilities. But she still was able to get a 6:30 p.m. appointment for the following Thursday, which really worked out for her schedule. So Rosa goes to the clinic. She walks in and checks in at the front desk. And then within 5 minutes, Joey, Rosa's medical assistant that's assigned to her, comes out to take her to the exam room. Once in the room, Joey starts going over a health assessment with Rosa and entering the data that Rosa says directly into her electronic health record on the computer, or perhaps a tablet. We don't know. And the assessment that they're going through is asking about a variety of topics. Her physical health, for sure, and extensive questions about her physical health and how her breathing is doing, because they know that she has asthma, because they were able to get her medical records from her previous provider and made sure to actually look at them before Rosa came into the office. But they also ask if she's had a dental appointment recently, if she's had a checkup there, if she has any oral pain, and if she's been feeling anxious in the last couple of weeks. Has she been feeling overly stressful, getting enough sleep, having trouble sleeping, or feeling any sort of depression or sadness? They want to make sure to cover all of their bases so they really get a picture of her whole health. So then Joey takes her vital signs, her blood pressure, again, make sure that she can breathe well, checks her breathing, asks if she's had any trouble over the last couple of years, if there was anything wrong, if she's been checking up on her asthma specialist, which she had not been doing. And she also takes her weight and height measurements. And then Joey exits the room, and Rosa waits a few minutes before her clinician comes in, who's Elizabeth, which is an ARNP, registered nurse practitioner, a registered nurse practitioner, excuse me. She comes in and introduces herself to Rosa. They spend a couple of minutes actually just talking about Rosa's life. Elizabeth understands that Rosa just moved there, wants to know a little bit about her 3 kids and how they're doing, how this move was it stressful? Did she have any problems moving? Was she able to find things around town? Any suggestions she could make? So really trying to develop that relationship with Rosa and making sure that Rosa could trust her as her provider. And then she starts asking Rosa questions about her health. If she had any health concerns she particularly wanted to address today. And Rosa says that she's been having some back pain. She also has not had her annual gynecological exam in a couple of years. So there's several different types of concerns that she wants to address today. So Elizabeth then takes the time to explain and go over with Rosa what their care plan is going to be for that particular appointment, and make sure that Rosa is okay with it and has any questions about it. During the examination, Elizabeth actually remarks on Rosa's change in weight. She's noticed that Rosa's gained about 20 pounds since the last time she was weighed, and she was already not necessarily too overweight, but reaching that threshold at her last check-in 3 years ago. So 20 pounds was a good enough increase that it was a concern to Elizabeth, and wanted to make sure that Rosa was aware of it, had any questions about it. Rosa explains that she's had a lot of stress over the last couple of years. She has now 3 kids. It's a lot to take on, and then now she's been moving and is trying to find a different job, and her partner's getting settled in. She's not able to work out or eat as healthy as she hoped. So at the end of the examination, Elizabeth really wants to go over with Rosa the next steps. One of the things that Elizabeth wants to do is make sure she connects Rosa to a new asthma specialist so that they have a relationship set out already, and if Rosa ever has a problem, a very serious problem with her chronic condition, they can connect with that specialist easily and make sure that they get the advice they need. And so Rosa agrees to that, understands that it's important. And then Elizabeth starts to talking with Rosa about her weight and asks if there's any ways that they can help support her manage her weight or help her get it down. And she goes over a few different options with her, that they have a dietitian or a nutritionist on staff that Rosa could see that could help plan out a care plan for how to reduce her weight and work with her on that. But then Elizabeth also gives the option of perhaps Rosa wanting to see a mental health counselor, because she calls out the particular things that Rosa mentioned in her health assessment, that she did feel a little bit depressed over the last couple of weeks, that she was experiencing some severe anxiety and a lot of stress. And Rosa contemplates this for a minute and actually decides to see a mental health counselor. And at this particular clinic, it's co-located, so that mental health counselor actually works in the family practice. So then, at the end of her visit, Gabby, Rosa's assigned community health worker, comes into the room to help Rosa schedule these next appointments. And she tells Rosa that they work with a great asthma specialist that actually specializes in adult asthma care as well as child asthma care. And they make an appointment together in the room with that specialist, so that they already have an appointment set up, and this is a relationship that can happen pretty immediately. And then Gabby asks about some of the different attributes that Rosa wants in a mental health counselor, so that they make sure that they choose the right one for her. And Rosa tells her things that she wants. She wants to see a female mental health counselor, that she really would like somebody more focused on family life than any other symptoms. And so based on those requests, Gabby actually makes an appointment for Rosa in the room for that for a couple weeks from now. So then, at the conclusion of this, what Rosa will do is go to that specialist, go to that mental health counselor. All of her health results will be reported back to her primary care practice at Clearwater Family Practice. And any future exams will be done there, including asthma exams and what they could do in the future. For instance, if every year Rosa needs to get a refill on all her medications and her inhaler that she has, that could be done at the family practice. And what they could do is just teleconference or a video conference in her asthma specialist, just to make sure that everything's going all right. That way Rosa doesn't have to make an additional trip up to wherever her asthma specialist happens to be. Okay, so that was tried to go through that quickly. I know it's a lot kind of to throw at you. But we also wanted to talk a little bit about the implementation in Washington of some of these different initiatives. There are several entities working with clinics across the state. A couple of examples are Qualis and McCall. They're 2 separate entities. They work with clinics everywhere to help improve their systems and actually get them ready to become NCQA certified patient-centered medical homes. And then that CMS demonstration project, which I explained about the FQHC1. We actually have 13 participating clinics in our state, a couple of neighbor care clinics up in Seattle, a couple of CMAR clinics, along with several others. And then here in the department, we have the Washington Healthcare Improvement Network, that already also known as WIN, which we did a webinar about back in October. And Nancy Olson, before she left the department, gave a great overview of the work. But they work in collaboratives in regions across the state. They've worked up in the Whatcom area, working with different primary care practices, voluntary primary care practices, and some behavioral health practices, and I think a pediatrician or 2 once in a while, to really transform their practices and focus on the outcomes that particular practice wants to achieve. And they do some measurement work with them as well, and they have to achieve certain a couple of required measures for the project, but then they get to choose, the practice actually gets to choose additional measures that they want to focus on and improve upon. So they worked in Whatcom County, like I said, it's South Sound around here in Thurston County, and I think they went into Mason County a little bit, maybe a little down in Lewis. And then now they're in the eastern side of the state. They're doing basically that Spokane eastern side corridor, which is great. And then under the Healthier Washington initiative, the Department of Health was named as the lead for the Practice Transformation Support Hub. So the main purpose of this hub is to align practice facilitation and quality improvement efforts in Washington state with the goal of assuring technical assistance and supports reach providers in the most efficient and effective manner. It is not the intent of the statewide hub to duplicate existing efforts in Washington state. In fact, the whole point of coordinating these efforts is to really cut down on that duplication and to work collaboratively to coordinate and strengthen and leverage all of these different improvements that are happening so that we're actually reaching all of the providers that really need them. There are 3 foci of the hub work, and so the way that we're hoping, I think it's going to work, is that we're going to have different technical assistance contractors that are actually going to be working with primary care providers, and they will be working on these 3 foci. The physical and behavioral health integration, which is a lot of what Healthier Washington is about, transitioning from this idea of an encounter-based system to a value-based system, and then community clinical linkages and what that really looks like when those work together. So for accountable care organizations, there are actually no Pioneer Model or Advanced Payment Model ACOs in our state, but we do have some shared savings ACOs, just 2 of them. The Franciscan Health System, and I actually think it's their provider group that's the one that's the ACO certified that works with Franciscan, and Polyclinic up in Seattle. And Polyclinic sees a majority of their patients are Medicare based. We also have a bunch of entities in our state calling themselves ACOs, but aren't actually certified by CMS. And so, which is fine. You don't have to do that. That's totally fine. But I think when we think about it, what we're concerned about is who's actually holding them accountable then. Who are they held accountable to for their patients' care? Because if they're not necessarily following or held accountable by CMS to follow their measures, then we don't know exactly what they're working towards. So Providence Swedish Health Alliance is one of the ACOs. They're a very big health system, and they're connected with the Boeing ACO. What Boeing decided to do with their healthcare this year is to actually, and it's not all of their health insurance plans, but it was a voluntary program that only non-union Boeing employees could choose, very specific and narrow. But what they wanted to do is actually take out the insurance plan altogether. They were already a self-insured organization, but now they really don't have any insurance plan even helping run their benefit design. So they actually worked directly with the providers, contracting with the providers to design what their benefits would look like for their employees. It's a different way of doing health insurance, and Boeing is taking on the risk, which they normally had, but taking on the risk of the health of their patients. And if the question is, if their patients' outcomes don't improve, then what does that really mean for the whole ACO? Does it mean anything, or will Boeing have to pay more than they expected, or will they all get to share in the savings together? Will that go back to the beneficiaries, the employees of the plan? So those are some of the questions I think they'll get ironed out, but a lot of people across the nation are actually looking at Boeing as a potential model to spread everywhere. And then Multicare is another one that is doing an ACO. They also have a clinically integrated network, so trying to get this wide network of providers to work together to make sure that they can share information with each other and coordinate care. So it's kind of all over the place. We really have ACOs across our state. And then there's the Accountable Care Network. So one of the 4 payment models in the Healthier Washington initiative is actually redesigning how we do PEB benefit plans, and one of them is this Accountable Care Network. They had an RFP that was released in I think it was released in December, and it was due in January. They received a number of applications and are reviewing them right now, but this is going to be an option for all of us as public employees in 2016, so that we could potentially go into this Accountable Care Network that perhaps could be a narrow network. That is what we're seeing with the accountable care organizations, much narrower network of providers, and where your quality of your care will actually be measured, and potentially the providers that you're seeing could be held accountable to your outcomes. So it'll be pretty interesting to see how that goes. You all might get a chance to test all of this out for us. So we all might get a chance. Okay, I'm going to briefly go over the role of public health, because this is something that we're still not quite sure what our role is entirely. There are some designs. There was a particular organization whose name is escaping me right now that released a report of what public health could look like in 2030. One of their visions was to have a community-centered health home, which has also been called the Community Center Health Commons, which really brings in all of these community clinical linkages that we've been talking about. So making sure that people aren't only have health care, but they're also connected to the right housing, that they have food security, that the food that they're getting is actually healthy food, that they don't live in a food desert, and we can really monitor the health of a patient because of those other factors that affect their health. And that all of these entities can work together with the patient at the center and the community at the center, and hopefully also share in that savings that then could be dumped back into the community. This other idea is around upstream providers and clinics, and again, trying to target whether or not in answering in a clinic setting whether or not people actually have access to housing and food and things like that. So something on a health assessment that could be included was whether or not they do, if they know that their house has lead, if they've done or participated in a lead screening program. That would be an example of something that could be included in a clinical assessment. That's an environmental factor. That's not necessarily something we think of as being included in a general health assessment. Another one is if Rosa, who had asthma, had actually got a home visit from somebody to do an asthma overview of her home to see if she had any factors that would actually cause her asthma to get triggered. And so things like that is something we're hoping to incorporate in the future. But we really need to know how to achieve this vision. We have to start sharing ideas among each other. Like I said, a lot of this isn't figured out for public health, and we don't really know what our place is. Here at the state, we regulate and do a lot of investigations into healthcare providers, and what does that mean for the delivery system? How is that impacted, and how does that impact the partnerships we're trying to make with healthcare providers? We also have a lot of programs, many of which are in this room, who are generating new partnerships with health insurance plans that we've never had before, breaking down those silos to really become a more integrated system. And we need to know what is really working and what hasn't been successful to learn from that and be able to then figure out what our different path is forward. And we also need to know kind of what, in general, I think everybody needs to know what sort of support we as public health need, as public health employees in all of our different areas need to really break down these silos and help participate in delivery system reform. So these are a lot of the questions we end up asking many of you, which I know some of you have already experienced that. And hoping that this can continue over the course of the next few years as we continue to transform. So I have to do one more slide for all of you because I want to talk a little bit about what's next for this work. So the Healthier Washington Initiative is getting going. We are sort of not shifting our focus, but in general, the department has decided to sort of figure out how we can embed this work on health systems transformation and innovation actually into all levels of public health and what that looks like, so that everyone can sort of get a sense and be able to speak to these, or at least understand how your work connects in a way that it doesn't necessarily all have to come from OS or the Office of the Secretary. And so part of the reason they're doing that is because there's been a change in positions. There was some budget decisions decided. So Sue's position, the special assistant to the secretary, is going to remain, and it's actually going to transition to be the Healthier Washington connector. Both the Department of Health and DSHS have one of these positions to really connect the project internally to the Healthcare Authority and then share communication easily. That's the goal of that position. So she will be the connector, and then there will just be one position under her to support the embedding of this work. And we actually don't know what the focus of the one person is going to be yet. We're having those discussions right now with leadership and trying to figure out what sits up here and what the divisions can sort of not take on necessarily, but can help with in terms of getting the work embedded and accountability for the work and things like that. So I think that's everything for today. You guys can all contact us here if you have any questions. And if you all in the room have any questions, please feel free to come up afterwards. So, thank you.
Thanks, everyone.